Thank you for joining us for our third session today of the Maryland Reproductive Health Roundtable Virtual Learning Series for summer 2022. Today, we're actually going to touch on a topic that may seem a little bit out of the norm for those of us in the community-based reproductive health services field: infertility. Typically, we counsel our clients and provide programming around birth control decision-making, sexual health well-being, and pregnancy prevention. When we have a client who is pregnant, we offer options counseling and then refer out to prenatal care. And usually that's the end of the conversation. But what about those patients seeking pregnancy but face barriers or challenges to reaching their family building desires? While we can counsel on healthy preconception behaviors, not every person has a direct path to parenthood. Whether our patients are a single parent by choice, a same-sex couple, folks with medical complications, or a litany of unknowns, the need for quality, affordable fertility education and services is a human right. In order to uphold a reproductive justice framework, we must work to broaden the lens with which we view reproductive health care. With that being said, I am so incredibly excited to introduce today's speaker, who's going to dive further into this topic, Dr. Camille Hammond. Dr. Hammond, she, her, is the CEO of the Tanina Q CADE Foundation. She is an expert on infertility education, advocacy, and support with work published in peer-reviewed scientific literature, newspapers, and magazines. Dr. Hammond's work has been featured across news and TV programs, and she has provided testimony to legislators on Capitol Hill about infertility-related legislation. Through her work at the Tanina Q CADE Foundation, Dr. Hammond has hosted hundreds of education conferences for families sharing about different ways to become a parent and overcome infertility. Dr. Hammond is also the author of several books, including The Good Book About Infertility and The Good Book About Faith and Fertility. She is also the owner of the publishing house, Good Books About Tough Topics. So I'm honored to welcome today's presenter, Dr. Camille Hammond.
Thank you so much, Charlotte. It is a real privilege and pleasure to be here with your group. And without any further delay, I'm going to share slides and we'll get started. Can everyone see the screen? Excellent. All right. Well, again, my name is Camille Hammond, and I am the CEO of the CADE Foundation, a nonprofit that supports families with infertility. And today I'm going to talk a little bit about the impact of a movement called Reproductive Justice on infertility and use of artificial reproductive technology, also known as ART, or fertility treatment. As a little bit of a background, the CADE Foundation is a nonprofit. It was started in 2005, and it was named after my mother. My husband and I struggled with infertility for many, many years and had many cycles of IVF, 6 cycles to be exact, never got pregnant. And after the last cycle, my doctor told us, "You're young, you're healthy, you have no more insurance, and this is not working. So you may want to switch your pathway to parenthood and consider either adoption or a gestational carrier," which in the lay community is just called a surrogate. And we were devastated. My parents were some of the only people who knew that we were struggling with infertility, and asked if my mom could carry a baby for us because they had seen a story on 60 Minutes many years prior to that point, where a woman carried a baby for her daughter who had a medical condition where she wasn't able to conceive. And initially we thanked them and politely declined their invitation, but after a lot of prayer and a lot of conversation, we decided to move forward and see if it was something that was even possible. Because even though I was a young physician, my husband was a young physician, they didn't talk to us about infertility and specifically about a woman carrying her baby, her daughter's children in medical school. Her doctor said she's healthy, it probably won't kill her, but we can't guarantee much beyond that because I didn't add earlier, my mother was 54 years old and postmenopausal at the time. But we moved forward, and about a year later, she delivered my triplets, who are now 17 years old. And so the first thing I want to share with everyone is no matter what you've been told, no matter how bad the prognosis or what has been shared with you about the likelihood of you having a child or having children into your home, if you don't give up, you will overcome. It may not be the way that you imagined or that you fantasized about when you were a young person, but you can have children if that is what you desire. One of the ways that the CADE Foundation supports families, and please, I know I'm talking a lot about CADE. I'm going to get to the topic in just one moment, but I did want to mention the family building grant. We do give out grants of up to $10,000 to help families with infertility, and we have a deadline that's approaching on July the 1st. So if you know of anyone who may have a need for financial support to help with the cost of either domestic adoption or fertility treatments, we have a grant available, and all of the information and the application is available online. And if they are able to apply, it takes about 30 minutes to apply. If they're able to apply, they'd be considered for the fall cycle, and that would provide up to $10,000 for fertility treatment. And we have supported 160 families thus far. So this is a great resource. And also on the CADE website, if you go to the resources page, you'll find out about another 50 or so grants that are also available from other organizations that will provide support, because we recognize that financial barriers are an important obstacle that prevent many families from moving forward with either fertility treatment or adoption. And so that is one thing that we're able to, at least in some way, address and help some families with the financial cost of those procedures. Moving on, before we get started, we have a few polls. So if will please pull up those polls. I'll give you just a few minutes to respond to 2 polls. The questions that you're going to see are, what is infertility? And then the second question is, how many days out of the month can a female get pregnant? And you may think that's easy. I know I talked about this with my grandma when I was little. Well, your grandma may have had different information that she shared with you. And you might find that some of this was not even shared in sex ed that you took when you were in middle school. So we're gonna review all that today in the class or in the session. And Charlotte, if you'll let me know when we are ready to move on.
Awesome. Folks are responding right now to how many days out of the month can a woman without any underlying medical problems get pregnant?
Okay.
All right, folks, I think if you haven't responded, this is your last 2 seconds. All right, and let's launch the results.
Okay. Okay, so this is very interesting, and I'm curious, and this is something that we could talk about offline at some point, where the information came from. The answer is 6 to 7 days out of the month. But when I took sex ed as a 7th grader or a 6th grader, I don't feel like there was any information shared about the number of days where a woman could conceive. I just thought every time you had sex, you could get pregnant. And that is certainly not the case. So thank you for your honesty and for responding to that. And we can talk a little bit about that later. Let's go to the next question. Has the next question? Okay, here we go. What causes infertility?
right, we'll give folks about a few more seconds to fill this out. If you haven't already done so, definitely let us know your thoughts on what causes infertility. All right, let's launch the results.
Excellent. This is also fascinating and important. A lot of people say, if you can't get pregnant, you need to relax. You need to take time off of work. You need to just kind of do things that don't stress you out. But the truth is, infertility is not stress related. It is not brought on by stress or fixed by the lack of stress, although addressing stress is important for overall mental health and wellness. But it is a medical condition caused by many different diseases or disease processes. Thank you so much for sharing those polls. So let's get into it. Let's talk a little bit about what infertility is and the types of supports that are available in the way that this treatment is impacted by reproductive justice. And if we could remove the polls, please. All right, so infertility is a big word with a very specific definition. It means a person has not conceived within 12 months of unprotected sex if they're younger than 35 years old, and within 6 months if they're older than 35 years old. It does not have any bearing on whether or not you'll be a good parent. It really isn't even related to your intention. So you can say, well, I wasn't trying to get pregnant. Your body doesn't know that. If you weren't using any form of contraceptive and you were having sex, within 12 months, if you haven't gotten pregnant, you have the diagnosis of infertility. It's very common and has been diagnosed in 1 out of every 8 people. So if you're sitting at a lunchroom table and there's about 8 people that are sitting around the table with you, someone has struggled with infertility or is struggling with infertility. But unlike many disease processes, you can't look at someone and know they have infertility. You can't say, her face looks a certain way or she wears a certain type of clothing. There's nothing to that would allow you to identify someone. So often people who struggle with infertility feel like they are alone. They feel like they're the only ones who are struggling. The causes are multifold and include things like endometriosis, which is a condition where the lining of the uterus, the tissue that lines the uterus starts to grow in the wrong place. So if it grows on the outside of the uterus instead of the inside of the uterus, or if it starts to grow on the colon, it's going to act like normal endometrial tissue, which sheds every month. It bleeds, and the normal. So if you look at your uterus as almost like a cup, this is normal endometrial tissue. When this tissue starts to grow out here or on other abnormal places, it's called endometriosis. Fibroids,
something like that.
Which are, I'm sorry, was okay. Fibroids are non-cancerous growths that are very common, unfortunately, in the Black community, but they occur in the uterus. They can occur in the uterine lining. They can occur in many places, but they're an important cause of infertility. Polycystic ovary syndrome, also known as PCOS, which can be connected with a host of symptoms: male pattern baldness, male pattern hair growth, obesity, diabetes, depression, high cholesterol. There are a number of medical issues that people with PCOS struggle with. A string of pearls, the ovaries often look like they have pearls embedded in the outside. And also I want to add that infertility is not exclusively a woman thing. 1/3 of the cases of infertility are male factor. And that means they're caused by something in the male. It can be that the sperm are misshapen. It can be that they're swimming in the wrong direction. It can be that there's a very low number of them, and it can be that the fluid that they're in, there's not enough fluid, the semen. So 1/3 of infertility cases are male factor, 1/3 of cases are female factor. And we talked about a few of the female factors before. And then 1/3 are either unknown factor or combined, both male and female factor. So my question is, we've talked about what infertility is, but is the choice of whether and how to have children a human right? And I agree with Charlotte said at the beginning of her remarks. I believe it should be a human right. And that is where reproductive justice comes into the equation. So before we advance, let's just talk a little bit about family building options for those who choose to pursue them, who struggle with infertility. Child-free by choice is always an option, or should be an option. But there are treatments such as in vitro fertilization, where the egg is removed from a female, the sperm is removed from the male. They are mixed outside of the body in in another container, and then the embryo is then transferred back into the uterus. And actually this picture here that you see on the screen is of an IVF. Usually they don't actually use a pipette to stick one sperm into an egg, but they can. When that's done, it's called ICSI, which is just another, it's another part of IVF, and it happens sometimes, but it's not always. Usually you would just see, 1 million sperm swimming around the egg. If people have IVF, they may not have good quality eggs. And so donor egg is an option, and also donor sperm. And those also are needed for people who are single and who are in LGBTQ, in the LGBTQ community, as they try to build their families. And then some, like myself, may also work with a gestational carrier, and that is another woman who would carry the baby but has no genetic connection to that child. Another great family building option includes foster care. And foster can be a temporary situation. It can be permanent. And there is also foster to adopt, which is also known as public adoption, and then private adoption, which would be through an agency. Public adoption and foster care is more often connected with older children. So if you wanted to have an older child, you would go through the foster care system, and often those are free. And there is also support provided to families that choose to adopt or to foster care to meet the needs of those children. Private adoption is usually for infants and babies, brand new babies. And then single parent by choice is another option. Again, single parent by choice, you would have to use donor gametes, and it could be done in a variety of ways. So now that we've talked about infertility, let's talk about reproductive justice, because it's really hard to have an honest conversation about infertility without also understanding the way it is unjust, or fertility treatment is not able to be accessed by all segments of the population equally. So again, this is a movement to identify first the barriers imposed on everyone by infertility. It is not fun. It is painful for everyone. But there are additional barriers or additional obstacles imposed on certain groups that make it even more difficult to access care. And these have outcomes that are undesirable for these groups. Included in that is the choice of whether and how to bear children. Like justice would say, you should not have to have children. But if that is something that you desire to do, then you should have the same access to services. Everyone should have the same access to services so that they would be able to pursue that in the same way. So in other words, fertility treatment at this point is just not accessible to everyone at the same level at the same rate. So what is reproductive justice? We just kind of went over a definition, but let's give some examples of what that means. So let's say you live in Baltimore or Smaltimore. You live in an area that is not geographically close to any fertility clinics. And if you are limited because you don't have a car, if you're relying on public transportation, even though a clinic may be, let's say, 10 miles away from you, how long would it take you to drive those 10 miles? Is there any public transportation that would even give you the option to getting a clinic or to seeing a provider within that area? And I can tell you, there are not many clinics in Baltimore City. Most of the clinics in our area are in the surrounding suburbs. Not having access to fertility care because you do not have insurance to cover the cost. Now, this is really important. There are only 19 states in the US where the legislators have actually created laws requiring insurers to cover at least a portion of the diagnosis and or treatment cost connected with infertility. But if you don't have the insurance, then you don't fall within the mandate. So in a state where there is a mandate, you can still not have access to care, but you don't have that because you don't have that type of healthcare insurance. Not being even told about infertility treatment options because your doctor would assume you would not have the resources to pursue them. So they may just decide for you, this is not something that she's going to be able to do, so I'm not even going to give her the information. Not understanding the information that may be available because you don't speak English well, and information is not provided in a language that is native to you, and you're not having someone who could translate for you. These are all issues that prevent you from from accessing services. Not having the money to pay for care. And this is, again, we only have 19 states where there's a mandate in place. So in most of the country, people actually have to pay out of pocket for these services. And one IVF can run upwards of $20,000 depending on your medical needs. So they are quite costly. And for most people who don't have an insurance, some insurance to help cover that, it can just be it just can be impossible. And I talked a little bit about how the foster care system is free, and adopting through the foster care system can be free, but adopting through a private agency can be quite costly. You could be spending upwards of $40,000 or $50,000. So this movement is very important because it requires us to speak truthfully about additional burdens on people who have infertile, who may lovingly refer to themselves as infertiles, depending on who you are. You may or may not identify with that title, but the additional burdens imposed by race, class, and geography. So who has the best access to care? There's a great study that came out recently. The people who are most likely to have access to services are in their mid-30s, they're white, they're educated, and they have household incomes that are greater than $100,000. There's a lot of people, though, who fall outside of that population, and they are referred to as invisible infertiles. They can include, but are not limited to, asked her, she's not interested in having children. She's 40 years old. I'm not even going to tell her about family building options. Non-white women, working class and poor women who may not have insurance that would provide coverage. Members of the LGBTQ community, people who live in geographically remote or isolated locations, those who are less educated, those with life-threatening diseases, those who are institutionalized, and also people who are part of the disabled or differently able community. So you might say, okay, that's all fine, but doesn't the patient also bear some responsibility for these issues? I mean, is it all other people's fault that they're not able to, or they're not accessing care. And Fertility IQ did a great video about this. And if you will give me. We're just going to watch this for a few minutes. Oh. Fortunately, as we chatted about earlier, there can be a real penalty to delaying fertility treatment. And unfortunately, African American women and couples tend to wait longer than they should. Here, we're going to cover why this tends to happen. One reason is that referring doctors tend to think of African American patients as being more fertile and thus less likely to need treatment. Let's talk about why that's wrong. First, the data shows African American women actually have higher rates of infertility compared to other races, and it's been on the upswing for decades. But most doctors fail to recognize this. As you can see, only 16% of doctors rightfully identified African American patients as suffering from higher levels of infertility. The ultimate result is that African American women aren't being referred along for treatment as quickly as they need to be. In some ways, it's up to the women and couples themselves to recognize these facts, because there's no guarantee that your OBGYN or family doctor will be attuned to it. Next, African American women may wrongly see themselves as being especially fertile. This can cause women to be overly optimistic of their own abilities to conceive. It's easy to point to celebrities who conceived well into their late 40s as cause for optimism, but what patients almost never see is the treatment those celebrities had to undergo to reach that point. Next, African American women and couples often place more trust in their community or religious institutions than they do in the medical system. As a result, African American patients are more likely to think of medical treatment as a very last resort instead of as a primary option. So reproductive justice is not something that's talked about in polite circles. Most national representative medical organizations have recognized this as a very important issue, a public health priority, and something that can be actually addressed and intervened upon. So it's something that we can work to fix, thank God. American Society for Reproductive Medicine issued a statement about this in 2021. The Association for Reproductive Health Professionals also issued a statement about this in 2021. The World Health Organization and the United Nations issued a statement about this in 2021, along with the Centers for Disease Control. And there was a joint statement issued by, I believe, 17 major health organizations, including the American ACOG, American Council for Obstetrics and Gynecology, the American Urological Association, and there were 17 of these major organizations that provide credentialing for physicians who work in reproductive health care, both for men and for women, that issued a joint statement saying that this is an issue and that provider bias is a major contributor to the issue. And that's important because that's something, again, that can be addressed and fixed. So why does it matter? Because people are having bad health outcomes based on this. There are significant disparities between African Americans and low income and non-English speaking, and some of these groups that I named earlier that are negatively impacted by lower access to reproductive services. And examples include disparities in death during pregnancy, miscarriage, as well as infant death between these groups in the larger population. Disparities in perinatal maternal mortality, that's the death of the mother around the birth of the baby, not necessarily, it could be during childbirth, but it can also be in the period immediately following childbirth. And this is actually going up. It's going in the wrong direction, and it has been going in the wrong direction for decades. Disparities in infertility. We talked a lot about the differences in the rate of infertility, as well as, well, Black women in particular are less likely to conceive. They're less likely to be referred for fertility care or for just medical evaluation. If they are referred and they have fertility treatment, they're less likely to get pregnant with fertility treatment. They're more likely to miscarry. They're more likely to deliver a baby early, and the baby have a very low birth weight or low birth weight, which places the baby at risk for sometimes a lifetime of medical complications. They're also more likely to have the negative pregnancy-related diseases such as gestational diabetes. And they're also more likely to die during birth and immediately following birth. And this is even after you control for things like education and income. And a high profile example of someone that struggled recently that you may have heard of in the news is Serena Williams. She almost died. She had a pulmonary embolus. She had a history of blood clots. And when she told the healthcare provider that was treating her, "I don't feel right, I think something is going on," she was dismissed, and she ended up having to switch providers to get someone to listen to her. Lo and behold, she had a blood clot in her lung that could have killed her. And she's rich, she's powerful, but she still almost died because she wasn't believed. Disparities in family planning, including prescribing of contraceptives, unplanned pregnancy, and abortion, and also racism impacting clinical decision-making. We talked a little bit about how these overarching, these large national organizations that are credentialing and providing ongoing support for physicians have said that racism is an important factor limiting access and impacting the clinical decision-making, which is limiting access to reproductive health care and support for certain groups of patients. So can this be improved, or are we, is this just a situation where there's nothing that can happen? So yes, we can do better, and we should do better. So some solutions include, so there are options for many different groups. And I think if we are willing to work together, slowly but surely, we can start to chip away at these issues and improve outcomes, morbidity and mortality for everyone. So for researchers, we need more studies to better understand causes and effects of health disparities and fertility outcomes and decrease these disparities. And we can develop better tools that healthcare providers can use to decrease the bias in how they make clinical decisions. For patients and advocates, we can work to educate members of the community about the issues so that they are aware and that they raise the alarm if they're concerned. So often people are scared to talk to their doctor, but if there are concerns, that they bring it forward and that they advocate for themselves, as well as the people that they are connected with. And also that they get good information about what infertility is, what infertility is not, so that they're encouraging people to seek care when it's appropriate, instead of discouraging them and telling them to wait or simply pray, instead of seeking medical support. For healthcare providers, and I said physicians, nurses, healthcare providers, but there's a lot of people that fall under that umbrella. We need to do better. We need better training, and we need people to apply the skills that they have developed in training to their clinical practice. It's not just something that's done to check a box, because the outcomes are are important for people's lives. People are dying that don't need to die because of poor decision making. That really is a reflective of individuals' biases. And for legislators, we need better laws. We need more legislated. We need more mandated, because unfortunately, so often if people are left to their own devices, if employers are given the option, services will not be provided and treatment will not be covered because, we do what we have to do and no more. But family building is a right. And if we really do embrace the fact that that is a right, then like other rights, they need to be enshrined in law so that everyone receives the benefit of those opportunities. So at this point, I'm going to draw my presentation to a close, and I'd be happy to take any questions. I thank you for your time and attention, and I'm going to start answering questions.
Yeah, I saw some people clapping in their videos. That was like exceptional, because again, as part of the conversation that we've been having with this series, and given that this is the third year of it, it's like really understanding the complexities of our reproductive health counseling practices, the services we provide, and understanding it's more than just like sort of this dichotomous, do you want to get pregnant, yes or no, that there's so many complications and nuances to that decision, whether it comes into our changing decision making that can happen per day, all the way up to where we're having this conversation now around the invisibility of infertility and like how we approach that conversation within our spaces. Definitely, folks, if you have questions, please feel free to drop them in the comment box. I'm keeping an eye on them, and I will share them with Dr. Hammond. I will start with a question I was sort of turning in my head, is that a majority of the folks attending these sessions, are connected to our family planning, our publicly accessible family planning clinics all over the state and city, as well as practitioners of different sorts, from medical to social workers to community health educators, providing support for folks in the community. So how would you recommend, Dr. Hammond, that, we who are counseling, maybe walking through birth control options or, having healthy pregnancy or postpartum, how would you recommend we start introducing the conversation of infertility into our counseling sessions?
That's an excellent question. And I would say that's actually appropriate for people even who are treating people, in other private settings. Often when a woman comes in for her annual physical, she's asked, how are you doing? Have you had any problems this year? Do you need more birth control? Do you need more contraception? The question is not asked, have you been trying to conceive over these past 12 months? So when you're asking about the need for contraceptive or that type of support, also ask the question, have you been trying to conceive? And then if you want to take it a step further, because mentally someone may say, well, no, I wasn't trying to conceive. But if they're not using any form of contraceptive, their uterus and their ovaries think you're trying to conceive. So another question may just be, have you been using any form of contraceptive these past 12 months? And pull out doesn't count, okay? So if they say, oh, we've been using the pull-out method, that doesn't count. So asking that question may actually just help them understand, even though you haven't been trying, mentally you haven't been trying, your body thinks you've been trying for the past 5 years. Because if they say, well, no, I never used birth control. But I've been sexually active with whoever for 5 years. Well, you have infertility. So if you, in fact, don't want to conceive, then, we may need to take some steps to make sure that doesn't happen. And if you actually are thinking now, wow, I actually want the option to have children, then that's something that you need to, you can begin to get worked up. You can get referred appropriately to someone who will do the testing, and then also see what's going on, because it may not be a huge issue. It may be, a hormonal issue that can be addressed easily, and that person would be able to go forward and have children. Sometimes you don't realize you want something until you think, I don't have that option. And then it becomes something that is very important because you realize that's not just something for the future. That actually, I want to be able to have kids. I want to be able to do that now. Great question.
Yeah, that's like really helpful. Again, that complexity, because I know we've been trying to, with some of our family planning initiatives, is like to introduce more information around fertility awareness. So, you touched on the question too of like the pregnancy, like how many days out of the month are you able to conceive? So just really expanding our information so folks understand also what's happening with their bodies, being able to track ovulation, to understand your fertility week, and be able to like understand a little bit more of that. So another question. Oh, sorry, please.
Really quick, could I jump in? So when we talked about you being able to conceive 7 days out of the month, it's not 7 random days. Like you don't get to pick your week. You have 7 days, usually in the middle of your cycle, between when you had one period and when you're going to have another period. And the best way to figure out when that happens is to go to the Dollar Tree or the Giant or, your grocery store or your local Walgreens pharmacy or wherever, and pick up some an ovulation predictor kit. There are these sticks. They look like the sticks that people use to detect pregnancy, but they detect when you have a surge of a hormone that bumps up when you're getting ready to ovulate. And it will tell you, okay, now is the time. That is when you need to make sure you're really trying. Everything else, sex during the rest of the month is just for practice. It's just for fun. You can only conceive during that window. So it would be worth the investment. Even at Walgreens, they're probably not more than about $10 or $15. Get those ovulation predictor kits so that you know when your fertile window is. Sorry.
No, that's really helpful, because that also teams up with like there's other tech that exists. So if folks are using period tracker apps too, they also make estimations of when they think your fertile window and ovulation would be based off of when your period is falling. So those are excellent tools. And I think really in the same vein of the question I had about like introducing infertility into our conversation, we also have a lot of folks who are health educators for young people. And so, what sort of messaging should we be including in our teaching, and how do we do it without scaring them or making it sound like it'll be a huge challenge to get pregnant? Because this is a question that is actually a little bit of context. What prompted us as a planning committee for this series thinking about how do we bring infertility into the conversation for our sessions was that we know a lot of questions have been coming up with young people around birth control use and infertility, the COVID vaccine and infertility. And so just really trying to like destigmatize, but also address misinformation that may exist. And so this question in particular is like, when we're starting that conversation with our young people, and what could those key points look like? Because some of these action items feel a little bit more geared for maybe adults.
So you brought up some important topics, and that so the COVID vaccine, pregnancy rates have been looked at pretty thoroughly by all of the large governing medical organizations connected with reproductive health, and there have not been any connections or associations with increased rates of miscarriage, increased rates of infertility. None of that has been connected with the COVID vaccine. So people do not need to fear that they're going to have a miscarriage if they take the COVID vaccine. Now, miscarriage happens, and it happens, unfortunately, quite commonly, but we can't say that it's caused by the vaccine. If someone has a miscarriage, it could be that, there was another issue, and sometimes, unfortunately, sometimes things happen, but there's been no association with the COVID vaccine. For younger people, I think it's important that they understand that you can't get pregnant every time you have sex. I feel like some of at least, I'm dating myself, but when I was taking sex ed back in the 80s, the information was more, let's prevent them from having sex. So almost let's scare them into thinking if they do anything, they're going to end up with a baby and they're going to have a very different life. Infertility happens in 1 in 8. It's very common. So I think in addition to teaching about anatomy and about the fact that, sex can be required in order for pregnancy. We also should talk about the fact that everybody doesn't get pregnant. Sometimes people want to get pregnant, and in 1&A, that doesn't happen. And I think that would be very helpful, so that you don't have 35-year-old women thinking that they are broken and that there's just something wrong with them because they're doing all the right things and they're not getting pregnant. They're not, quote unquote, giving their husband a baby. Well, it could be male factor, which is very easily diagnosed, by the way. So often women they want to go and they want to get worked up and see what's going on. Male factor is literally ejaculate in a cup, and they can test everything. And if it's male factor, it's very easily treated, versus female workup is much more expensive, much more invasive, and much more costly. So I just think we need to start speaking truthfully about pregnancy and not hiding half of the information, so that we can scare teens out of having sex, because these teens grow up, and if they grow up with certain assumptions based on bad information, that can really cause them to have some serious long-term questions about themselves, and look at themselves in ways that are just not truthful.
That's like helpful. Again, like, as we do with birth control, counseling in general, like so much of it is addressing myths and misconceptions. And so the idea is not necessarily like a free for all go pass for our young folks, but just being honest that this might be something that they might navigate as they get older, especially like as you talked about the impact of like polycystic ovarian syndrome or endometriosis, like those can dramatically impact fertility. So just making sure folks have transparency and that information, so that way when they do come to a place in their life that they are, seeking to grow their family, like that they understand that there might be other challenges at place. And actually, you had touched a little bit on miscarriage, and that's we actually had a question that was brought up by one of our fabulous home visitors, that if we have a client that has had multiple miscarriages, but the doctor is not addressing the issue, what are some ways that you would recommend us sort of, I guess, like how we counsel and sort of talk about this topic, because miscarriage does fall under the large umbrella of infertility and possibly seeking out fertility support and care?
So we call them fertility doctors, but they're actually reproductive endocrinologists. So they are endocrinologists who focus on the reproductive systems. I think that when someone has had multiple miscarriages, they deserve a referral to at least figure out what's going on. Are there, if there have been any studies done on the embryos? Was there something chromosomal that was showed? Is there a uterine issue where she just has an incompetent cervix, and that can be fixed by throwing a stitch in there? They call it a cerclage. Or is it something else? But I think at the minimum, those patients deserve a referral to someone who does this on a routine basis and is able to investigate to see if there's something that can be addressed. Because that can actually be traumatic. Getting pregnant can be traumatic for people who have had recurrent miscarriages, because they're afraid of miscarrying.
Yeah, that's like really helpful as a reminder that, again, that there are specialized physicians and practitioners in this field, the reproductive endocrinologists, and that there are a wide range of tests and procedures that can be done to like help support that family building journey, especially with reoccurring miscarriage. So again, just trying to get a referral out to that. And that actually brings me to another question around any recommendations, Dr. Hammond, you might have for support groups or therapists for, we'll say, folks dealing with infertility.
Yes, I think support is the best thing that everyone can and should do for themselves. It doesn't have to be costly, and it can feel like air, like when you are suffocating. Support can feel like air. There are different kinds of therapists, and I would absolutely recommend that you see someone who has a background in fertility counseling. So depending on where you are, I would do a quick Google search. The American Society for Reproductive Medicine also lists resources on their website, therapists who are credentialed and experienced with providing support to families with infertility. But online, there are a number of great support groups on Facebook. For African American families, there's a great group called Fertility for Colored Girls. And I know that at one point they were meeting in person. I think that they went virtual during the pandemic, but they may have resumed in-person meetings. The Broken Brown Egg, which is another amazing resource for women of color. But Resolve, the National Infertility Association, is also an outstanding organization, and they also have support groups for women. Often these support groups are free, and plugging in online is certainly free. So care is available. And another side benefit is they share great information. So, this kind of crowdsourcing of knowledge, especially when it's good and it's accurate information, can be very, very helpful. So I would recommend those three. Oh, no.
Awesome. Those are incredible, incredible resources.
Thank you.
Oh, can you hear me?
Mm-hmm. Yep, you froze for a second, but I see
Awesome. Awesome. Yeah, I wrote down those recommendations. And so we will make sure after today's session, when we send out the post-meeting materials, that we include those resources. Those were excellent. So I guess on behalf of everyone in today's session, Dr. Hammond, I want to give you a big round of applause and thank you so much for an incredible presentation, really insightful. I mean, I'm speaking on like a community health educator level and community clinic level. It is so amazing when we can further grow the information we share with our patients and our communities and like help them make the best decisions that work for them. So thank you so much for today's presentation.
It was my privilege. I appreciate the support, and thank you for listening.
Absolutely, absolutely. So thank you everybody for attending today's webinar, and in the next few days, you'll receive the post-meeting materials, as well as recording of today's session. We have a couple different resources we're gonna send out with you. The recordings are going to be housed on the Maryland Department of Health website. I think we put in here the evaluation link. If we did not, we're gonna send that out in our post-session materials. Please, please, please fill out the evaluation link. That is great feedback we're able to share back to Dr. Hammond for future topics and discussions. Certificates of attendance are opt-in during registration and are also sent out by the end of the week with our partners at Healthy Teen Network. So if you have any questions, please feel free to follow up with them. And as always, take care of yourselves. Thank you so much for being part of today's conversation. Thank you again to Dr. Hammond, and we look forward to seeing you guys in July. All right, everybody have a good rest of your day.
Be well. Bye-bye. Have a good day.